This is EHJ Today at the Cardiology Update in Davos, Switzerland. And I'm Tom Lüscher, Editor-in-Chief of the European Heart Journal. I'm talking to Professor John Deanfield from London, who just gave a lecture on lifetime risk at our Congress. Welcome, John.
Thanks, Tom.
So, John, what is lifetime risk?
Well, Tom, you know the clinical problems from atherosclerosis don't usually emerge until we're middle-aged or older, but the underlying pathology that underpins the disease starts decades before that. And it's become clear that the same risk factors that we've known about for years that are related to heart attack and stroke in later life are actually involved in initiating and driving the process of atherosclerosis during that long preclinical period. The idea of lifetime risk is to incorporate strategies that will actually tackle not just the late clinical risk, but also try to do something to slow or prevent the development of this disease from many years earlier.
So you have to have worked a lot with children, which we as adult cardiologists usually don't see. Does this also already apply to childhood in some way?
It's very interesting, Tom, that the process of atherosclerosis actually begins in some children in the first decade of life. And actually there's evidence to suggest that events that go on in utero before the child is even born may actually program their arteries in terms of future susceptibility to atherosclerosis and cardiovascular risk factors. So early life infancies are clearly very important.
And as an adult cardiologist, when would I have to think about this? I mean, usually they don't see children, they see adults. When does it become important, do you think?
Well, clearly the cardiovascular risk factors that drive atherosclerosis vary between people. Sure. So if you're just a normal young person in the community, the process of atherosclerosis probably begins to become established in your 20s and 30s. So that's the time when we should be thinking about modifying or making sure our lifestyle is good. And of course, earlier on, teaching children to eat well, to exercise, and live a healthy lifestyle is a very good investment. Yes. Now, if you've got a family history or a genetic predisposition, say familial hypercholesterolemia, actually the process begins in the first decade of life, and you can show that with tests like IMT in the carotid and other such tests.
What's new then in this field of lifetime risk?
Well, the concept of lifetime risk management means that not only should we be doing what we've done quite well for years, which is trying to pick out the high-risk people who are going to get into trouble or are likely to get into trouble over a short period of time, say 10 years. Yeah. We should also be looking to see what we can do to identify people who are on that wrong trajectory to get disease over many years and start to do something early to try to prevent them getting into trouble in later life.
Yeah, as cardiologists, we basically see the patients at a very late stage
Yes.
of the disease where many things are not reversible.
Yes.
Now, most of the scorecards that we use, be it from the US or from Europe, are actually a bit short in duration. They look at 10 years. Now, if you're 50, maybe you're not only interested in what happens with 60, but maybe 70, 80, which is the life expectancy today many people have.
So 10-year risk is the classic way of quantifying cardiovascular risk and deciding on whether or not to introduce therapies like statins, blood pressure medicines and the like.
That's what the ESC does.
And that's what all the guidelines have done up to now. Mm-hmm. And there's a reason for that. It's because those people are clearly at high risk of a clinical event. And if you're introducing new therapy that is expensive or of uncertain efficacy or safety, you start off by looking for the people who are at the highest absolute short-term risk and are likely to benefit the most from treatment. And that's why these guidelines were designed to do that.
Basically then, if you're female and young, you have no risk whatsoever, independent of your actual long-term risk. And if you're an old male, you have a high risk anyway. And is that the problem of the...
So you're absolutely right, Tom. That encapsulates the problem in the sense that the biggest drivers of short-term risk are age and male sex. So that elderly men like us are at high short-term risk over 10 years. And yet, younger people, and particularly women, who may have very important modifiable cardiovascular risk factors, at an early stage are still at a low short-term risk and wouldn't qualify for an interventional strategy despite the fact that they have cardiovascular risk factors.
But isn't one of the problems that most of the trials that and evidence that we base our decisions on were running for 5 years really, rather than the long-term perspective that we have in mind as we talk about lifetime risk.
Absolutely right, Tom. The information that's emerging comes from either genetic studies, which predispose to exposure to risk factors over your whole life, or from evidence from longitudinal studies where we've looked at subclinical markers of atherosclerosis as they develop. And both those two approaches have told us something that we haven't thought about perhaps well enough before, that it is exposure to risk factors over many years that is driving the emergence of this disease. Those same risk factors, smoking, cholesterol, blood pressure and the like, are operating to damage our arteries and progress atherosclerosis during that first 50-year window.
Could you give an example of a genetic mutation that would exemplify this concept?
Well, there's been a lot of interest around a new controlling mechanism for LDL cholesterol, and it's called PCSK9. And this has actually become a very important and interesting target for therapy these days. But the first evidence for this came from a mutation that was picked up in an American study that showed that if you had a mutation of the PCSK9 gene, unexpectedly at that time, there was a reduction in LDL cholesterol of about 28%. Now that 28% lower exposure to LDL cholesterol over time translated to a very impressive reduction in future cardiovascular events. It was actually 88% in the 3% of subjects who had that polymorphism. And that really told us something about lifetime exposure to LDL cholesterol and later cardiovascular risk. So that's where the investment component comes from.
Peter Libby showed the slide on LDL levels in evolution, showing that humans have like 5-fold higher LDL levels than, let's say, primates or any other mammals. So shouldn't we do this a preventive strategy in everybody, because we're prone to the disease anyway because of this genetic makeup that we have compared to other mammals?
Well, it's probably a combination of a genetic makeup and the way in which we live that drives the risk factors that drive our future atherosclerosis. And there's plenty of evidence to suggest that if we lower our risk factors with a healthy lifestyle, that we will have a very profound and beneficial effect on our future cardiovascular risk. So you're absolutely right. There's nothing against living a healthy lifestyle from an early stage. In fact, if you want to invest in your arteries, that's precisely how to do it. So early lifestyle.
Yeah, but is this effective enough? I mean, if we compare, at least in the short term, statins to lifestyle changes, it's several-fold more effective. Should we use statins then more liberally? Like in the UK, this is a pill-taking society these days, you told us during your talk.
Well, we've got a new calculator that assesses lifetime risk as part of the new UK guidelines, which are called the Joint British Societies 3 or JBS3 Consensus Guidelines. And what we did in the JBS3 calculator is to assess not just short-term risk in the conventional way, but we also assessed the lifetime risk of patients and actually the population. So we calculate novel metrics like your heart age, and we calculate the time which you can expect to have your first cardiovascular event with your particular personalized risk factor profile. Now, what that does is to teach you some interesting things when you start to play with that calculator. The first thing you see is that if you want to do lifestyle interventions that will produce relatively modest reductions in cardiovascular risk factors, you need to do it early and you need to sustain it. If you modify your cholesterol, blood pressure and the like, and of course stop smoking at an early stage, and you maintain that, you get a very important benefit later on. That again is the compound interest from early intervention. Now, if you take that same individual who then decides not to do anything about their risk factors for 30 or 40 years and comes back, as they often do to us in clinical practice, in their 50s and 60s, you really have to drive down those cardiovascular risk factors to get the equivalent benefit. So in a sense, it really empowers people to understand that lifestyle changes really make a difference, but not when you're 60. Right. You have to do it earlier.
Right. So where is then the place of cholesterol-lowering drugs that are today mainly statins, but maybe in the future some others? When would you start that?
Well, they're clearly patients who are at high short-term risk of a cardiovascular event. And we calculate those in the JBS3 calculator in exactly the same way as the European guidelines have done and the American and various other guidelines have done.
So that
if you're at high, that's exactly the, okay.
Right.
So if you're at high cardiovascular risk over 10 years, quite clearly we have the opportunity to reduce that risk by medications like statins, novel cholesterol lowering therapies, or even blood pressure agents, or any combination of those treatments. The interesting thing comes when you start to look at where we might benefit people over those first 40 and 50 years, when their short-term risk is still low, but we know their arteries are exposed to those risk factors. And for most people, we can demonstrate that an early intervention with lifestyle will actually produce a benefit, and they may not need to take the statin or the blood pressure medication later. Of course, there are other people who have, for whatever reason, a high risk of a cardiovascular event that's programmed from early on, and the classic example are familial hypercholesterolemia. And of course, no one would argue against trying to modify the LDL cholesterol in a family with FH who have a high cardiovascular risk. So the drugs are indicated from an early stage in high-risk people, and may be indicated more and more when we have comorbidities that we know also increase the risk of cardiovascular disease, diabetes, kidney disease, or the like.
Very good. Thank you very much, John, for enlightening us on this subject.
Pleasure.